Well, in terms of functional operability, we are still using the 2009 guidelines, but these are being revised as we speak, and they will be published, probably they will be published this year. So it's still nothing new on that side. On the contrary, on the technical resectability, well, until recently we didn't have a consensual definition or agreement within the community about what would be a resectable stage 3. Meaning that with this neoadjuvant and perioperative trials with immunotherapy, the patients that were included, this is quite a heterogeneous population. So we have varying proportion of patients with stage 3 and also with N2 disease, and there are trials in which even 40% of the patients have N2 multi-disease, which is something that in the past we consider unresectable. So this has a bit shaken up what we consider resectable, but it also had more confusion, I think, to the discussion, and that's why last year the Aortic Lung Cancer Group launched this initiative to have a consensus definition of resectability to be used in clinical trials, so to improve the standardization of patients included in trials. So this is not meant to be directly applied to clinical practice, although we know that probably some people will start also using this for clinical practice, but that's not the aim of this initiative. It's really to be applied to trials. And we have the collaboration of multiple societies in Europe, respiratory, the pathology, the surgeons, radiation oncologists. It was a really multidisciplinary endeavor. And what, after a lot of discussions, what we agreed on is that first we need to have a very thorough workup when we diagnose our patients. So high quality PET-CT, contrast-enhanced CT scans, and all brain MRI, and also pathological assessment of lymph nodes by EBUS, EUS, mediastinoscopy, whatever you want, as long as there is a systematic staging of the mediastinum. And then all these medical specialties that I've just mentioned should be involved in the discussion. And we went through each of the subgroups of patients, but to give you like in a nutshell, what we have is that for the small T1, T2 tumors or the T3, T4, T2 size or satellite nodules, these are considered resectable if we have absent or limited lymph node involvement, so N1 or N2 single station, which is in the new TNM classification will be considered as N2A. So these are resectable. On the other extreme, we have the tumors with large, very important lymph node involvement, like the N3, the N2 bulky, that these are usually considered unresectable. And then we have this gray zone, which are the patients with N2 multiple station, for which we could not reach a consensus. So what we say is that these cases should be really discussed in a multidisciplinary way, in a case-by-case selection, in which these patients could be eventually be included in trials with surgery. And also we have the T4 invasive tumors, those that invade diaphragm or the mediastinum or others. Again, there are some structures that are potentially resectable and others that are not resectable. So this should be discussed also with very experienced surgeons, and if doubt, refer these patients to high volume centers to have an assessment.